you to become a psychiatrist? And then after that, why an academic psychiatrist specifically?
Right. Well, Mike's just mentioned that I've had an interest in developmental origins of mental disorders, and I think there are developmental origins of my journey into academic psychiatry. So I was quite a sickly child. I had what was diagnosed as celiac disease or gluten sensitive enteropathy. This is right back in the early 1960s when it wasn't very well recognized. I had almost 6 months of being fed overripe bananas because at that time, 1962, when I was in hospital for a long time with this failure to thrive, it was known that one thing that children could tolerate was in that position was overripe bananas. So how did I go from overripe bananas age 2 or 3 to becoming an academic psychiatrist? Well, I think I became interested in medicine from a very early age. And even at primary school, late primary school, I was given a textbook of anatomy and physiology for nurses by Ross, which I can still remember, which I devoured and used to read before going to bed. And this interest in medicine persisted through secondary school. And looking back, my family, like many families, there were many family members who had mental disorders, neurological disorders. I had an uncle, very able man, who had a stroke and developed a vicious expressive dysphagia, which used to frustrate him enormously. He could understand what we said, but he couldn't put into words the answer. So I was sort of primed, I think, to be interested in the brain and the mind through medical school. And I found psychiatry absolutely fascinating when I was first exposed to it at medical school. The sort of what we now call intersectionality of it, I think that it exists in between other disciplines. So it draws on neuroscience, psychology, social science. And I think being a good psychiatrist should be the art and science of drawing on all those different disciplines. And there was one patient when I was an undergraduate on my placement in psychiatry at Queen Mary's Hospital in Roehampton. And interestingly, she was a middle-aged lady, recently retired professional. And she had absolutely awful, agitated psychotic depression with delusions that she was incontinent and that everyone else could smell of urine on her. It wasn't the case at all. And she had ECT, she was given ECT, which is something as a psychiatrist now, I've only prescribed ECT twice in my whole career. But she was given ECT, and after 2 treatments, this all melted away, this delusional system. And she became the confident professional woman once again. And I just thought that was incredible. And that guided me, I think, towards psychiatry further. But I did some general medicine after I qualified because I thought that was a good thing to do. And then wanted to have something specific in my early postgraduate training towards the brain. And I put in 2 applications at pretty much the same time. One was to do some neurology jobs, and the other one was to do psychiatry. I was working at King's College Hospital at the time in London. And the psychiatry one at the Maudsley Hospital came up first, the interview, and I guess the rest is history. And I knew a remarkable group of people, or a group of remarkable people who are a little bit ahead of me, including one Michael Owen. I'd been interviewed by, one of my interviewers there was Robin Murray, and he offered, I did my first job with Robin at the Bethlehem Hospital, and the rest is history, I think.
Great, thank you.
So it was a 2-decade journey, almost 3 decades actually.
So yeah, the next question was, what do you think are the most important ways to encourage early career researchers? And I guess whether there was anyone who encouraged and inspired you. You mentioned a couple of names already, but yeah, it'd be great to hear about that.
Yeah, well, I think Robin Murray was certainly a very powerful influence on me, and I think what he did for me and many others who of my generation who went on into academic psychiatry is that he just gave us opportunities actually, and very expert guidance, but freedom to explore. And I think in the schizophrenia breakout room, and I'm sure in the other breakout room, we saw 3 examples, you included, Poppy, of people who'd been guided expertly, but given a lot of freedom to be creative, freedom to fail, freedom to go through the whole academic process of protocol writing, implementation of the study, and all that entails, right through to publication and exploring where that might go next. Interestingly, I did a secondment to the Department of Health, like you did, a little bit later in my career, for 2 years part-time. So again, was able to see a little bit more about that journey. Perhaps we'll come back to that in putting things into practice.
Yeah, there's a later question on that.
Yeah. There were other people who were very influential. And I've been a bit of a magpie with mentors, I think it's important to take the positives, but all of us have strengths and weaknesses. So it's important to look at your mentor's weaknesses as well. And so at an early stage, I worked for Michael Rutter and doing child psychiatry at the Maudsley. And of course, Mike Rutter had reviewed anything. You asked him a question and he'd say, well, look at my review I published last year. And he was also very good at encouraging early career researchers to review systematically, actually at a time when the systematic review that, as we know now, wasn't really so well developed. So he was very good at encouraging early career researchers. If they wanted to ask a question, he encouraged you to answer it properly. If it's a serious enough question, you need to take the answer seriously. And then another mentor, Mike mentioned, I spent some time at the London School of Hygiene, was Michael Marmot. And Michael, who we know now about social inequalities in health, this was 25 years ago, maybe longer, and he was at the beginning of his thinking of social inequalities in health. And so he would encourage early career researchers to think in that interdisciplinary way that I mentioned earlier, which has been very influential on me. So I suppose for senior people, encouraging early career researchers is about giving them space to be creative and supporting them. And I've been lucky in my mentors. And I think for early career researchers, it's to look at your supervisors and mentors and look at the good bits, look at the bad bits, and reflect on how you want to, what you want to take from them.
Perfect, thank you. Quite a big question next is, what do you think are the most important things we've achieved in the last sort of 30 years or so of mental health research?
So 30 years, that takes us back to about 1990, doesn't it? Well, I think a number of things have happened. So thinking about clinical research and mental health services, I think there has been, I mean, it's very easy to say, oh, nothing's happened in psychiatry, we're using the same old treatments. But I think there have been some really remarkable changes. So one, and they're not across the board, they haven't reached all areas of mental health, but I think we've got a lot more ambition. And so I caught a conversation between Marjan and Laura Davidson at the end of the breakout session, really about tolerating unsatisfactory treatments. And I think we do that a lot less now, and that's evidence-based. We're much more ambitious about what intervention should be giving patients, and thinking about not just symptom reduction from the point of view of the clinician, but about overall quality of life. So we're ambitious about what our intervention should be doing for people. Over the last 30 years, we've completely revolutionized the way that we include patients, service users, whichever vocabulary one's happy with. We've revolutionized the way we include their voice and include them as partners in research. I know that Thomas Kabir, Vanessa Pinfold are on the call, and the McPinn Foundation has been an important part of that. But I think it has got hold in research much more mainstream, and we lead other areas of health. Mental health leads other areas of health in that. What else has changed? Well, I think thinking about biopsychosocial model. I mean, in the biological sphere, I think in neuroscience, we move towards systems neuroscience, which is a sea change from 30 years ago and before, when I began learning psychiatry. It was a much more sort of lesion, localized based approach. We now think more systems based in neuroscience, systems based in genetics. We're bringing in immunology, thinking of that as a systems based approach. So I've lost my train of thought a little bit, but I think those are some of the most important changes that we've had in the last 30 years, and also bringing in the environment again. So the way that many papers in schizophrenia research used to begin with the same sentence. So schizophrenia is a devastating neuropsychiatric disorder that affects 1% of the world's population. Of course, those things are true, they're also wrong. So the ambition for recovery in mental disorders, I think that's been very important, and also a recognition that some people can recover in a rather personal way. Recovery is personal to people, but recognizing that, well, I've mentioned ambition quite a few times in this answer, but that people can recover from these disorders has also been an important step.
Yeah, absolutely. And I guess off the back of that, where are we going next? I know you've been involved with the development of the mental health research goals for the next decade, which was something we spoke about a lot in the Department of Health when I was there. But yeah, where are we going?
Right, that's interesting. I'm glad they got talked about in the Department of Health. So you must have come across Alison Tingle and Ursula Wells. Yeah. So for mental health research goals, yes, well, I had a small part. The development of these goals was led by the Department of Health, but was a tremendously inclusive process. Again, McPinn was involved, Vanessa, all the major funders, and not everyone may know what the goals are. So this process over several months, perhaps the best part of the year, came up with 4 goals, as you say, Poppy. And they're ambitious stretch goals. So they acknowledge a developmental life course approach. They acknowledge that the origins of the disorders that we see emerging in adult life have often had their seeds are sown in childhood and adolescence. So goal 1 is to undertake research that will halve the number of children and young people who experience persistent mental health disorders. So trying to break the awful continuity across the life course that there is. Goal 2 was something else that's actually come out of the last 30 years research, is the link between mental and physical health, which is something that's been really transcends the brain, mind, body divide that is like a shadow over our field, actually, that we don't recognize the links between brain, mind, brain and body. So research to improve the understanding of the links between physical health and then eliminate the mortality gap. And this is the fact that people with serious mental disorders die too early, 1 to 2 decades too early, so they lose life. So these conditions can be fatal, not just through suicide, which is important, but the way that these disorders don't stop at the neck, they affect the whole body. Goal 3 is about research to improve new treatments, interventions and support for mental health problems. So mental health services, I think there's often a lack of clarity that the services there are, the purpose of service is really to deliver interventions. There's care, which is very important, context of those interventions, but we wanted to make sure that there was a focus on improving interventions. And then goal 4 was a rather more socially orientated goal, which is about improving research to improve choice and access to mental health care treatment, whether that's in hospital or community settings. So it's a huge canvas, actually. But I hope that those goals will, they're meant for funders as much as researchers, actually. So MHR UK is taking heed of these goals. So I hope that they will help shape research over the next decade or so.
Perfect. Thank you. I think that's all we have time for, sadly, but thank you very much. Really, really interesting to hear.
Pleasure.
Yes, thanks very much. And thanks both of you for an excellent and very compelling interview. So we've now got a brief break. And as I said before, you're going to have to log back in, I think, to a separate Zoom meeting, and we're back at midday. So thank you, everyone. Thanks, Peter.